hospitals who are empaneled to CHS is
but
saying,
we are not using anything now.
But let's not discuss that controversial point. We go to next case. Dr. Sushil is back from the previous hall.
This is not a case of a reused balloon.
Okay, this is stunt balloon. We know that.
There can be many ways of retrieving
this
I
also fractured a new
balloon. Do
balloon.
it in the other ways.
Dr. Sushil, please. Yeah, please.
Dr. Sushil is here. He just lying back,
Okay. Prevention and early detection of complication in structural heart interventional cardiology. Okay, Dr. Sushil.
I think I'll go through several procedures and some complications. In the end, a lot of this comes to planning, but sometimes things just bad things happen and you get bad luck. This is a case of a patient, we had this introduction to the Impella. In the US now we have a right ventricular Impella device. It is a 22 French system, and basically you put it from the femoral vein, and it sucks from the right ventricle and injects into the PA. So, once the patient didn't need the Impella anymore, the device is simply just pulled out, and you pull it out and you hold pressure on the vein, and you hold pressure to achieve hemostasis. In this particular case, we took the Impella out. And the device was pulled into the IVC, it came out, but this is all that came out. So that's not the entire device. If I go back and show you the picture, this is the entire device. So what was left in the patient was this entire segment. It had fractured off in the IVC. So patient is brought to the cath lab, and you see that the device is there. It goes all the way down to the femoral vein, and it's right here at the end. And the tip of it is up here. So now the question is what to do. We called surgery. They did not want to, they said it would just be too much of a bloody mess. They'd have to go retroperitoneal and try and repair everything. So we tried several different approaches, and I'll go through our thought process. So we talked about snaring. Trying to this shaft has a hole in the middle that the pump is going through. So theoretically, you can get a wire in, try and inflate a balloon and engage it that way and pull it out. Or do you just cut down, or do you use a bioptome? Do you try and grab it under fluoro guidance? So what we started with was we tried to put a 24 French sheath below. It's a 22 French device below the femoral bifurcation in the vein under ultrasound. And so we had to barely get alongside it there. You see, we're alongside, and we try to use large snares to try and grab it, but we could not. So then we got this is the attempts with the snares. There's just no room in the vein to get around the device, and we simply could not get around it. So then we got a 6 French multi-purpose guide. The wire went through the device now. See, the wire went through the device. So we got a guide up through the device as well now. We inflated a balloon inside the device. You can see the balloon goes through into the edge of the device, and the fragment still stayed stable. So inflated the balloon and tried to grab it, and you see where the balloon's pretty well inside, trying to pull in, but the balloon just keeps slipping out. The inside of the surface is hydrophilic, probably, and we can't engage it. So now we're like, okay, that didn't work. So then we decided to re-advance it of putting it up higher and getting better control. But in doing so, the device got pushed up to the IVC. So now we made a situation worse. Now we got the device back in the heart, but there's still a wire through the device. So we still have a wire in the device and still have some control. But now we sort of managed to get a balloon somewhere in the middle, and we're pulling it back. And we get to the sheath, but we can't engage it into the sheath. So you could just take the sheath out and pull everything out, and you'll probably, with a local cut down, be able to grab it, was one thought. Or we could try and snare it at the top of the fragment to help support it and pull it down. And so what we did here, we have this multi-purpose wire through, and then we were able to get alongside. So now we were able to snare the pigtail portion, the top of the device. So now we have a balloon below, and now we have a snare. You'll see eventually we have it grabbed on top. And so now we have proximal and distal control. So now you can pull it from the top and you have stabilization to help it get into the guide below. And with that, we were able to pull it into the sheath. And this was a segment that had broken off inside the patient. It's unclear why it broke off, but that was one way to do it. We talked about whether we could go alongside, above and below, and what would be other options as well. Now, I'm not sure from the session, I have 2 other complications I can show. Do we want to have a discussion here with this? Or?
There's a small comment
like
about
to
this case
discuss,
first. See, if that balloon is slipping away, you can take big size balloon,
Yeah.
number 1. Number 2, you can make the surface of balloon rough by just rubbing the spirit along with it. Yeah. Third thing is, you change the sheath to higher size. Once you have wire across it, change the bigger sheath so that it comes into sheath. This is about 3 months about this case. Dr. Hand.
I think the simplest technique would have been going from the left sides and catching the pigtail, because you're catching the fawn body wrong way.
Right.
You're catching from the bigger part.
Yeah.
See, if you catch from the pigtail side, there is always a taper from a larger sheath to a pigtail which is smaller. If you catch it from the smaller side, going from the left groin, and then the pigtail will very easily enter the sheath. Now you're getting a problem. There is a misalignment. You're not able to pull down. Pigtail you can always catch with the help of a snare. I think would have been very easy job to pull it down. Or you could have gone from SVC. Yeah. Jugglers are bigger than the femorals, and you could have pulled it up.
I think that.
And once you were like this, then I think you can always wipe with alcohol. The
balloon.
like we do alcohol septal ablations.
Yeah.
And during that, we treat the balloon with alcohol so that it doesn't balance it, and hard pressures. And the second thing possibly also could have been, see, wherever you pass the snare, your balloon could have gone higher, and you inflated the balloon higher rather than putting a snare, and that balloon higher will be bigger than the lumen, this, and then
The impeller at the edge,
Inflate the balloon
won't
actually
go
the vessel,
through.
distal to the device.
Wherever edge is there, whatever is the size,
Yeah.
you can always pass in a balloon. Let's say the edge accommodates 2 millimeter. So you take a new 3.5 millimeter balloon, inflate it, and it will come out.
No, I think the challenge, I think what would have been a better approach, as you
From
suggested,
the other
was-
side,
no,
juggler other side would
the
have been
other
the best.
side, this thing will kink. So pulling it up and over, that was the concern.
No,
the stiffness.
catch the pigtail.
Ah.
Once you catch the pigtail and you have a big sheath either in the jugglers or in the femoral,
Right.
and then pull it down.
Yeah, I think the easiest thing, in retrospect.
Jugglers are bigger than femorals.
Yeah,
But
and
easiest
also
is-
you would pull up and the bullet of the device would come into the sheath much more easily. The back end of the device is what was not able to, when you put a snare on here, it was kinking the device. So putting a snare on here, putting a,
According to me, catching it from the bigger part is the wrong way of catching it.
Right.
Whenever you have to catch such kind of a device, always catch from the taper part,
Yeah.
because the taper part will easily get into the sheath.
Agreed.
So if you catch the pigtail part from the other, on the left groin, it will easily come.
Then why to make the procedure complex? What I told was, use a bigger sheath, use a bigger balloon. What is wrong in that?
No, that the wrong is, let me tell you, the bigger part, many times you are not able to keep it coaxial. So as you are trying to pull, you will just tear the
Slip
vein.
off.
So
And it might
slip
tear
See,
the
you can
So
slide your sheath over it. Nah? Instead of pulling it back,
No, if-
you slide
if-
over sheath over it.
Yeah, if you have a bigger sheath, you can
You
gulp-
slide
you
over
can
sheath
gulp
over
the
it.
device
Don't pull
over
it
that.
back. Nah? So you cover it like guideliner.
But contralateral is very easy. In contralateral, you may not need a bigger sheath. You just need to catch the pigtail. Once the pigtail is out of the groin, then the whole
No,
device.
but
Ways instead of pulling it back,
contralateral or
push
pulling
the
it
sheath
around
forward.
The horn, it's a stiff device. Pull around the horn. I think IJ would have been the better approach.
Now the device is already at bifurcation there, so there is almost nothing.
Right. No. But I'm saying but I don't. In retrospect, we were discussing it. I would have just gone IJ.
Juggler, juggler
Yeah,
is
that's
better.
just the easiest
Straight,
approach.
more straight.
Straight off. So next real one. So in the end, vascular complications occur in structural heart more so than anything else from oversizing the device. A sheath to femoral artery ratio of 1.05 has been predictive. We do in all of our structural interventions with large vessel access, we get a contralateral wire. So if we're going with the big sheath on the right side, from the left side we put a wire up and over and we pre-close. And the reason we do it is every once in a while when you come out, so that way when we're coming out, the sheath is coming out here on this side. On the contralateral wire from the right side, we're passing a 6 or 8 millimeter balloon going up and over. And if there's a perforation or anything, we can inflate the balloon. And then as we take the sheath out. Every once in a while, this is what you see when you push the limits and you oversize the device. And we push it a lot. And this is one where you see an iliac rupture. So the question here is what to do. Do you go vascular surgery? Do you stent from the left femoral artery on the other side and close? Or do you stent from the same side? what we did here, the key thing, any of these cases, is to get control of hemostasis. First thing, don't worry about fixing it. Get control so the patient doesn't bleed out. So on the other side, we advanced the balloon, we inflated in the common iliac, and we got control, so there's no bleeding. Then you take your time and think. So from the same ipsilateral side, we put a 10 by 80 covered stent, so from the same sheet that we had taken out. Then we tied our per-closed sutures, and we let the balloon down. Why is this not advancing? You see the final result there. You have control. We have a little bit of thrombus because we had reversed. That will go away with time. But you're able to control it from the other side. And I'll just show a couple other examples of other ways to approach the same problem. Whenever you have a femoral access complication, the contralateral side can be your friend and can manage all of this. So this is an example. We took the sheath out and we see a perforation, but we had a contralateral wire. So simply over the wire, go from the other side, 9 French sheath, go bareback, deploy. This is a fluency stent, self-expanding covered stent. In general, we use self-expanding stents. Final result looks fine. In general, calcium is the problem, but a lot of it is just oversizing. You got to have enough room. And the sheaths have gotten smaller, but the results have gotten better. But the reality is in these patients, you're going to have issues. Like tortuosity like this can cause a problem. You can see here the sheath is kinked. A kinked sheath is a sharp edge. If you have a kinked sheath, you can perforate the vessel as the sheath comes out. You should put, if you're going to take that out, try and put the dilator back in so you don't damage the vessel. To try, in patients with tortuosity, you have to try and straighten out the tortuosity. Here's a patient with extreme tortuosity. What we did is on the contralateral side, we put 2 stiff wires. So you have access on both groins. In this, there's abdominal aortic tortuosity. You can see now that we have 2 stiff wires, these are Meyer wires, and when the 2 stiff wires, that aorta is straight. So we leave the stiff wire in until the sheath goes in, until the valve goes in. And then I take the stiff wire out of the contralateral side, and I haven't caused any damage. You see here the valve went up over that stiff wire, and then subsequently you were able to do the procedure without a complication. You just have to be careful in some of these scenarios because you're going to get into access like this with calcium and tortuosity. For example, you can create a bad injury. Look what's happening to this core valve. The nose cone is, well, you saw it there for a second, but the nose cone is bending. You keep pushing, you're going to perforate the iliac. And the last thing with vascular, whenever you use a large access, do a completion angiogram. I see a lot of people, 2 per closes done, there's no flow, there's no bleeding, it's fine. But sometimes, if you don't do a completion angiogram, you're going to miss things like this. Here, the closure looked good. There was no bleeding. But there's a near-occlusive dissection. If you ignore this, when the patient wakes up, they got a cold foot and everything else. This is very simple with the wire. You can just inflate a balloon and gain. You saw there on the other side. We had a wire across and just put a gentle balloon. We didn't probably need to stent at all in this case. Just tacking up the dissection. If you don't do a completion angiogram, you're going to miss it. So whether it's TAVR, endografts, whatever you're doing with large vessel access, you need to do a completion angiogram. And I think that's one of the keys. And these perforations can occur anywhere. This is one where we did a transaortic procedure. Patient went home, but 2 weeks later came to an outside hospital with respiratory symptoms. She got a CT for PE. But look, I don't know if you notice this here, but see this contrast here? That's a LV pseudoaneurysm. We had perforated the LV with our nose cone and wire, so she developed this contained pseudoaneurysm. And you can get with this with any device in the LV, any wire. So this lady wasn't surgical. With the injection here, you can see the pseudoaneurysm filling. You see this here, this pocket. That's the pseudoaneurysm. On here, you see the flow into it, the color flow. So crossed into it with a glide catheter, and we put a 8 millimeter Amplatzer vascular plug to seal the neck of the pseudoaneurysm. And over time, this is you see the plug there being deployed. It's simply a nitinol plug to try and close the aneurysm. And over time, it completely closed off. So these are all different perforations that we've caused with structural. We've caused perforations in the femoral, in the iliac, in the aorta, in the LV. The key is to be prepared and how you can manage those without surgery. All were managed endovascularly. So I'll stop there if there are any other comments or questions.
I think it was a great presentation. Just besides this point, are you still doing in USA TAVI under general anesthesia, or are you doing with a conscious sedation?
Most of the patients are with conscious sedation at our institution,
No.
but I think it varies from place to place. You know, I think either one is fine. You can make an argument for either side, whether it's awake or asleep. I think it's just being prepared for the complication. Actually, you know, I'll show you one thing. You know, sometimes you can get away with really stupid
Because US
stuff.
was a little slow to catch up with the conscious sedation which Alan Krieger had started off. You were still doing general anesthesia for quite a long time.
Yeah, no, and the reason the general anesthesia, here's a case where it does help us, right? So, severe LVOT calcium. We did a BAV, everything went fine. Can I get the
Dr.
slides?
Sheel, can we go to next case, please?
Oh, sure.
Next presenter.
Okay, no problem.
Yeah,
Okay.
now we have a next presenter, Dr. Gaurav Chaudhary, please. Dr. Gaurav Chaudhary. Sorry. Thank you. Is Dr. Gaurav around? If Dr. Gaurav is not around, can you go to Dr. Bansal, please? Dr. N.O. Bansal.
He's already done.
He's already done.
K. Subramaniam.
You are? On behalf of Dr. Nishant. Yeah, over one. Dr. Nishant.
Nishad.
Right?
Nishad.
On behalf of Dr. Subramaniam. Yeah. Right.
Good evening, respected delegates, professors, and my dear colleagues. Today, I'll be presenting on behalf of my professor. My name is Dr. Nishant, and I'll be presenting a case, post-perforation rotablation facilitated PCI. So the history is of a 60-year-old male who presented with history of acute onset of chest pain. He's a known diabetic and hypertensive. He's a known case of ischemic heart disease, status post CABG in 2007, where Lima took and in this setting, he was diagnosed to have an ACS with evolved lateral wall MI. He was treated with appropriate antiplatelets and antithrombotics, and patient was subjected to an angiogram. So the left shoot, the angiogram revealed there was a distal LMCA 30% stenosis with the proximal LCX tight 90% stenosis, and the proximal LAD was totally occluded. The RCA shoot showed proximal RCA near total occlusion with distal vessel faintly visualized through bridging collaterals. So the Lima graft angio, it showed a patent LAD graft with collaterals, the left system giving collaterals to the right system. So to summarize the angio findings, there was a left main 30% stenosis, there was an occluded LAD and RCA, the proximal LCX with a tight 90% stenosis with a patent Lima to LAD graft. So based on this, we've taken the patient up for an ad hoc PDCA with 12CX. So the lesion was crossed with a 0.014-inch floppy wire, and then the lesion was pre-dilated with a 2.5 into 10 mm semi-compliant balloon. So after the pre-dilatation, we could notice some localized stasis of dye around the balloon dilated segments. So this was suggestive of a contained perforation. So then we've taken a 3 into 10 mm semi-compliant balloon, and we've given a prolonged inflation at the site of the perforation. So here we could see that the perforation was sealed off, but the lesion has not yielded. So this is subsequent shoots where we could notice that the perforation has sealed off completely, but the lesion was still the same. So continuous monitoring of the patient showed that the hemodynamics of the patient was stable. There was no hemodynamic compromise post-procedure. There was no evidence of any pericardial effusion or tamponade on echo. So then we were stumbled with the question of what to be done next. So then one option was to manage the patient medically, or next, because it was a very tight, non-yielding lesion, whether to take the patient up for a rotablation at a later date. So because the patient persisted to have angina despite maximal dose of anti-anginals, with the option we went with was to do a rotablation followed by PTCA. So the patient was called back after 4 weeks, and the patient was taken for a repeat procedure. So here we've used an exchange length PTCA wire, crossed the lesion, and then using a microguiding catheter, we've exchanged the PTCA wire with a 0.09-inch rota wire, and we used a 1.5 mm rota burr. So post rotablation, we could see that there is improvement in the lesion, angiographic improvement, and then we've pre-dilated the lesion with a 2.75 into 10 mm, dilated to 16 atmospheres. And after balloon dilatation, there was good lumen development, and there was angiographic improvement. Then we've used a 3.5 into 30 mm drug-eluting stent deployed at 14 atmospheres. So this was a shoot after the stent deployment. So then we've taken a 4 into 10 mm non-compliant balloon, and then we and we inflated to 16 atmospheres. So this was the final shoot after the procedure. So this is the same shoot. There was significant lumen growth. There was a good TIMI3 flow that we've established across the LCX. So this is the pre and the procedure shoot. So for us, in this case, the take-home message was the pre-procedure assessment of the lesion characteristics is vital in planning an appropriate interventional strategy and avoiding complications such as the content perforation in our case. Since the patient was stable in the initial procedure, after content perforation, a successful redo procedure could be attempted after 4 weeks. And ROTA helps in preparing the bed for PDCA in such calcific lesions, as it helps in facilitating delivery and expansion of the drug-eluting stent. Thank you.
I think his point is well taken. Thank you very much. Good case. Point is well taken. Any comments, or we just go to the next case? You are Dr. Subramaniam or Nishad?
He's my professor.
Okay, so you are going to present another case now?
No.
Dr. Nishad is separate one. Now we invite Dr. Nishad.
Okay.
Thank you.
Nishad. He is Nishant on behalf of Dr. Subramaniam. Is Dr. Nishad around? Please.
Naveen Garg then.
Good evening, respected delegates. We are now going to probably the 6th case of a ruptured stent balloon and a broken shaft. So it's not as uncommon as we think it is. So this patient, he was a 67-year-old male, a hypertensive and diabetic, and for 3 years he had class 3 stable angina on maximal medical therapy. And his CAG, which I'll show you later, showed a heavily calcified long lesion of the LAD. And even after 3 years, the patient was persistently refusing CABG. So finally, we decided to go ahead with rotablation, followed by 2 stents to the LAD. And this is what happened. This is the angiogram. As you can see, it's a long LAD lesion, heavily calcified. There's no question that this cannot be done without a rotablator. And 1.5 mm rotalink burr was used. The rotablation was fine. There was no issues with that. You could do it smoothly. Polishing runs, everything was done. Then it was pre-dilated with 2.5 by 12 non-compliant NC Sapphire balloon at 22 atmospheres all throughout the entire lesion. And then finally, this was the first stent, 3 by 40 mm Sarolimus eluting stent, which was deployed at nominal pressures of 10 atmosphere. But when we tried to deflate the stent, we got blood in the indeflator. Checked on what we saw here on the angio was that the balloon was partially deflated and therefore it got stuck. Now naturally our first reaction whenever something is stuck is to pull it, and as expected the shaft broke. So now the fun started. So we initially tried to take a balloon for entrapping into the guide, but it was not reaching the end of the guide. Probably because it was getting intermingled with the broken shaft which is still inside the guide, and therefore we could not be sure whether it will hold or not. So we decided to try some other ways. So first we tried putting a wire parallel to the balloon, so that hopefully we'll be able to maybe inflate a smaller balloon next to it or something like that, or try twisting, but we could not even get a wire across. The patient started having ST elevation, angina, so he was intubated. Only fortunate thing which we had during this entire procedure was that probably because of 3 years of ischemic preconditioning, the patient did not have any arrhythmias. So he was intubated. We sent an emergency call to our bypass surgeon, only to know that he is in theatre on another CABG case, and it will take at least 4 hours before we can get the theatre ready. So now for 4 hours we had to keep trying something. Now it took us around 30 minutes to finally borrow a micro snare from another lab. So we got a Cook 7 mm gooseneck snare, and this snare did get a hold of the shaft of the balloon, but what it would do, whenever it would hold the shaft and we would pull, it pulled out the balloon maybe a mm or two, and then the shaft would get cut. So some 6 or 7 cuts later, finally the snare managed to hold the end of the balloon marker, and we were able to pull the balloon partially into the guide, and then the snare snapped. The snare itself broke. So the balloon was now partly in the guide, partly in the LMCA, and partly in the LED. But this time, because most likely because all the pieces of the shaft had been cut out, we were able to use the balloon entrapment technique successfully. The balloon we could take all the way up to the distal end of the guide, trap it on the stent balloon itself, and then of course rest was easy. The whole thing, we could withdraw the entire assembly in block. It came out of the groin sheath also without any problem, primarily because it was a 7 French guide and a 7 French sheath, so we had adequate room. Now I've skipped a few slides for sake of time, but we were going to put a second stent proximally anyway, and of course the proximal LED had got pretty well dissected because during all this maneuvering. The first stent which we took, the second stent which we took in, that too the balloon got torn, but it got torn before inflation, so we were able to take it out. And then a third stent, this is the third stent which went through. It was inflated successfully. Nothing happened to this balloon. This was 3.5 by 20. And this is the final result. So final result was good one. So this is what we have here. Now I'm not going to go into the theory of this, but so many cases already taken place. But basically, heavily calcified lesions are going to remain a challenge. And while rotablation is most of the times mandatory for a really badly calcified lesion, but you can still have problems like a stent balloon rupture. And of course, that's a cath lab nightmare, as you can see. But we were able to manage this without surgery, fortunately.
Excuse me, you could have put a new wire and a new balloon and crossed the
we tried
balloon
crossing a wire, sir. The wire we were not able to cross. Tried for almost 15 minutes to get a wire across it. The balloon was partially inflated. The wire just did not cross it. So we had to try something else. Finally, when we got the snare, we were able to get some benefit, some pull-on, and then finally we were able to trap
we were
it.
lucky. It's very difficult to get the snare and...
Yeah, we were lucky, true.
No, CTO technique should be used. Say, this is a recently deployed stent and a balloon, and it is not, which is cemented. It's not a cement. So you can take a microcatheter there, you can take a tornus there very close to the non-deflated balloon, and then you can have a hard wire, and then you can always, with the support of, backup support of a microcatheter or a balloon, millimeter wise wire, and you can, I don't think it's, but if you want to take a simple and a soft wire, they may refuse.
No, we did not try that actually.
But if you have any experience of CTOs, they can be easily crossed, and once you cross it, take another balloon there, deflate it, then because if you look at it, once you were trying to pull out, your guiding was too deep into the stent. It is possible that you would have pulled out the stent also.
It's quite possible.
Those things. Second thing is you did not take an excess with the other guide. Contralateral
we should have done that.
should always be there. Thirdly, as you are pulling out, if you had the guiding with you, rather than pulling from the groin, first check what is there in the coronary artery, because many times you are busy in the groin because the balloon is not coming out, and you have created a problem there and you are totally unaware. So I think those standard things should be observed in all cases.
We are beginners. We learn No, okay, we'll invite next question.
Every time I hope that they will not be there, but every conference such cases are presented.
They are going to be there.
Dr. Naveen, please. Thank you, boss. Dr. Naveen.
How to prevent forearm complication radial interventions?
It's difficult to sit 2 hours. Good evening, everybody. Today I shall be discussing about how to prevent forearm complication in transradial interventions. And I will be focusing on a very simple, newly developed technique to prevent forearm complications. There are so many complications which can a patient develop after transradial PCI. The commonest are radial artery span, excess site hematomas, forearm hematomas, and radial artery occlusion. And this is the main culprit. If you have this thing, your patient, if you cannot treat or that complication, patient may develop compartment syndrome and can be a catastrophe. So recently I developed a technique which is given name pigtail assisted tracking of the guide catheter. So before going into the details of this technique, I will like to show you a case. The patient was a 61-year-old female with past history of stenting through the right femoral approach. And she was presented to us with recent onset angina, and ECG echo was normal. So she was taken up for coronary angiography, and while this time we took the radial approach. So during the radial angiography, the diagnostic catheter could not be negotiated through the radial artery, and patient complained of severe chest pain, severe arm pain, and even the 3-5 wire that could not be crossed through the elbow region. Then the radial artery angiogram was done, and which showed a 360-degree loop. So then a Teramo wire was taken, 3-5 Teramo wire, and it passed easily under the vision, and it has straightened the loop. And after that, the angiography was completed, which showed a severe lesion in the LAD with patent stent in the RCA. So the plan was to do a transradial angioplasty of LAD. So when we took the guide catheter could not be negotiated into the through the radial artery, and patient complained of severe arm pain, and every time we were pushing the guide catheter, patient complained of severe pain. So multiple doses of cocktail were given, but there was no effect. So we suspected that there is a razor blade effect. So what is the razor blade effect? When we have a 3-5 wire in the guide catheter, there is a white free space in the guide catheter, between the wire and the guide catheter. And you have a free edge of the guide catheter which is, will remain in the touch with the radial artery, and this edge of the guide catheter, it produces the injury into the radial artery. So this is the basic mechanism of this razor blade effect. This is the diagram, and this razor blade effect is especially noticeable if your patient has got some tortuosity in the radial artery, because in that particular part it may give it has a propensity to give injury into the radial artery. So what I did is I inserted a pigtail catheter inside the guide catheter. So by doing this, the pigtail basically is a longer catheter than the guide catheter. So both end of the pigtail catheter were outside the guide catheter. This distal end was out of the distal end of the guide catheter, and the proximal hub of the pigtail catheter was outside the guide catheter. So it is making a assembly, pigtail plus guide catheter assembly, and the basic benefit was that it is basically obliterating the free space in the guide catheter. So by doing this, I have avoided the razor blade effect, and this assembly went inside very easily, and this was the real time crossing of the radial loop using this pigtail and guide catheter assembly, and it was negotiated easily through the subclavian artery and finally into the ascending aorta, and then the wire and pigtail was taken out, and the angiography was angioplasty was completed. And this was the basic mechanism of benefit. Now you can see there is a smooth tapering. This is the guide catheter, this is the guide catheter, and this is the pigtail, and this is the wire. So it is making a smooth tapering. So by doing this, you are avoiding this razor blade effect. And this is the cut section of the same phenomena. This is the guide wire, and this is outer one is the guide catheter, and between these two, this is the pigtail catheter. So pigtail catheter is basically obliterating that space and avoiding the razor blade effect. And then the angioplasty was completed in usual way, and the radial angiogram again showed no injury by doing this procedure. In another patient, there was a tortuosity, and simple guide catheter could not be negotiated, and by this technique it was easily this is the guide catheter which is not going, and the same patient, now the pigtail guide catheter went very easily, and the angioplasty was completed. This was another patient in which there was a severe long segment spasm in the radial artery, and guide catheter was not going, and the assembly went very easily. and the post procedure, there was complete relief of the sponge. In another patient, there was a focal radial artery sponge and guide catheter was not going, but this technique worked very well in that particular patient. In another patient, actually, when we completed the angiography, there was a radial artery perforation and the severe sponge. And then we did this same technique, and the angioplasty was completed. And after completion, the radial artery angiogram showed complete relief of the sponge as well as the sealing of the perforation.
How sealing?
And now we have evaluated this technique in a prospective randomized trial, and which has clearly shown that if you do radial angioplasty, transradial angioplasty, you can reduce the forearm complication rate by 50%. So to conclude, during transradial angioplasty, sharp edge of the guide catheter may act like a razor blade and can prevent the catheter navigation, and is the major reason for the development of forearm complication. And it is especially common in radial artery loops, tortuous radial arteries, and small caliber radial artery and radial artery sponge. And this PET technique can overcome this razor blade effect by pigtail working as a dilator of the guide catheter. And it is very easy to perform, and it provides a non-traumatic negotiation of the guide catheter, and should be the technique of choice in such a situation to prevent forearm complication. Thank you.
There's one more method. You take PTC wire, take a balloon, 3 millimeter, 3.5 millimeter, inflate the balloon partially into the guide and partially distribute the guide. That travels much faster. But your technique is better.
But
you know
this
why?
technique,
Because you already have a 3-5 wire across it.
Yes,
You need not put PTC wire again. So if this technique doesn't go, then you can use that technique. But this technique seems to be better because you already have 3-5 wire.
Yeah.
That is good technique. But this technique definitely
that
better.
Technique is also very good, but it requires a special PTC wire, and
It requires more time and more procedure.
much difficult to do. It is much easier to
If
do.
it doesn't go, then we can use that technique.
Yes.
Your technique is
Yeah,
definitely
yeah,
better.
yeah,
That can be done. Yeah.
That can be done, but it is another alternative which is much easier.
Now you have, see, this is something not new. I think probably you're not aware. Sometime, some 20 years ago, we used to use directional atherectomy, and we used to have 11 French guiding catheter. And 11 French guiding, you can understand the kind of razor effect you will have. The company used to give us a stylet. Like if you have to introduce a check flow, if you have a 8 French check flow, you cannot introduce an 8 French check flow with a 6 French dilator. You need an 8 French dilator, because if there is a space, it will not go. The company used to give us a dilator, which was for the 10.5 French catheter. Now for sheathless radial UCATs, they also have a stylet. You do not need this pigtail business. This pigtail business, I told P.K. Goel some 7-8 years ago, I think they have done thesis also on it, which has come to me, that we have been using this pigtail into the catheter. It is okay for like a poor man's process, because you still leave some space and you still disfigure the catheter. It is, as far as balloon assisted technique is concerned, balloon assisted technique is very, very simple, very easy. The only thing is, you do not have to inflate the balloon at high pressures, because at high pressures this will become stiff, it will not bend. You let the balloon only just nose cone part of the balloon be just outside the guiding catheter, and any guiding, because let's say you want to use a 6 French or a 5 French, then sometime the pigtail will very snugly fit. It's very easy to take a 5 French pigtail into a 7 French guiding, but a 5 French pigtail into a 6 French guiding is at times a snug fit, which may,
5 French pigtail goes very easily.
okay.
Both has to be new.
But
Both
both
catheter
has
had to
to
be
be
new
new.
then.
Yeah.
what I'm telling you is that it is not always that kind of a fit. Sometimes it is a snug fit, whereas a balloon assisted tracking is a very, very simple technique, and in fact this technique should be done both for forward as well as backward movement.
Actually, you need a snug fit actually to prevent the razor blade
This technique is
effect.
also
You
good,
need
but practicality of this technique seems to be slightly better because already have 3-5 wire across it. There's an individual opinion. That's fine. Now, go to next case, please.